circumstances, we had to shift this OSCE from first Thursday to this time. So let's start with the OSCE today. And for this, I welcome our President, Dr. Jhankhana Sanghavi Madam, for her welcome address.
Good evening all. Thank you, Nehal. I welcome respected Baldev Prajapati Sir, Dr. Lata, Dr. Nehal, and all attendees. See, OSCE is very popular now. And what I think, OSCE by Prajapati Sir, for the students, it's like an Arjun's bird eye. Single shot and win exam swayamvar. This is like that only. And for the pediatrician, this OSCE will help for the pinpoint diagnosis, very specific things, and reduce our OPD time. OPD time increase થઈ જાય. So this is the what is the advantage? What are the advantage of the OSCE by Prajapati sir? And not taking much time. Thank you, sir, for the excellent OSCE every month, week, every monthly. Thank you, sir. Thank you. Over to Dr. Nehal. Mute, sir. Nehal, mute, sir.
Yep. So today we are going to have OSCE again with the neurology. And sir is going to take all the cases of neurology. Either it is ANS, CNS or something related to neurology, which may not be ANS and CNS. So let's see what surprises comes for us. And I thank Dr. Lata for her constant effort to join us and to propagate the Gurukul to all the students as a chief coordinator. So platform is all yours.
Thank you very much. Yes, Lata. I think Lata is speaking. Please.
No, sir. Nothing, sir. So just it's all yours, sir.
Good evening, everybody. And thank you, all of you, for taking, I will say, pains and to manage this type of the teaching sessions. It's nice to see because now I'm familiar with some of the students from different places. Dr. Nikhila is probably from Hyderabad. I remember even the places also.
Yes,
Dr.
sir.
Aditi,
good evening, sir.
Yes, good evening, Nikhila. I think you are good students. Please, even you can raise the questions, queries. Dr. Aditi, I know probably she's from GCS. Dr. Dhananjay, yes, Dr. Nandini, Dr. Nikita, because all these students have participated in our different sessions and their presence makes a difference. I know that there will be the presence of these students, particularly the exam going, and with that even the OSCE related some of the questions also will raise, so that probably the whole topic will be almost covered. And even sometimes suppose the full question is asked, then also they can have the ideas. You know that the full questions can be there on neurocutaneous disorders, neurodegenerative disorders, tuberculous meningitis, even the space-occupying lesions, even the SSP. I know all these questions and I have gone through the last, I will say, Gujarat University papers for 10 years or so. So keeping in mind all the points, we'll try to make it more, I will say, interesting and particularly the exam oriented. Now let me start to share my PPT. Is it seen?
Yes, sir. We are already started. Yes, sir.
Yeah.
It's a full screen.
Yes. Is it full screen?
Yeah, yes, it's there.
Fine. Again, Dr. Lata, I think you can help me.
Yes, sir. I'm ready.
Yeah, to check even the chat box so we can incorporate all these questions, queries.
Yes.
I think I will start from the point from where we stopped last time. I remember Okay, this was the last OSCE during our last session. Let us start from here. A 10-year-old boy was referred for gradual worsening school performance, behavioral problems, and decline in cognition for the 6 months. He also had complaints of frequent falls and sudden jerks with injury marks over the forehead for last 4 months. The child also had seizures. EEG was performed by a pediatric neurologist and was reported with some specific interesting changes leading to the diagnosis. And this is EEG. Let me mention over here that I'm not expert in that EEG. Somehow I was not trained, and later on I didn't try to learn much, but some basic things I know. I will keep the picture for some time. You can try to look at the picture, that what does it suggest. I will say every point in the scenario is very important. You can correlate that scenario with these EEG changes. And therefore, now my first question, what is the probable diagnosis? With this scenario and EEG, again, if I show, you can concentrate over the points in the history and the EEG, and then the question is, what is the probable diagnosis?
One answer has come by Aditi, SSP.
Very good. Anybody else? Nikhila, what is your idea?
Sir, even I think it is SSP, sir.
Okay. I'm sure that you are going to face one more question. What specific past history may favor the diagnosis?
So history of measles in the past, fever with rash.
If you are doing SSP, probably this question is easy. But the third question may not be that easy. What is the specific EEG finding expected favoring the diagnosis, which is shown in this picture? That means we'll have to learn some EEG also. Exam going students, at least, they will not put the complicated, but very common conditions they do keep even in the OSCE. Yes, anybody?
Yes, sir. Answers have come. One Dr. Bejugam Omnibus Gupta has answered PLED. Aditi has answered Redemacher complex.
Okay, good. At least they are responding. But please remember, in the OSCE, the answer should be very precise. And therefore, I think that periodic high amplitude delta waves, that is the correct answer. And I think the first person who answer is right. Further, but what is the confirmatory investigations? Suppose if you want to confirm, EEG is highly suggesting. It is one of the criteria, yes, with this given scenario. But is there any confirmatory investigation, which is probably more specific compared to even the EEG?
So measles IgG from CSF.
Okay. Nikhila is speaking, am I right?
Yes, sir.
Okay.
Yes, sir.
Anybody?
No, sir.
CSF, yes, but which any specific idea?
Anti-measles IgG titers. Dr. Aditi has answered.
Okay. The question is CSF anti-measles antibodies. And why I don't specify the antibodies? That IgG of some concentration, I think they have defined. But if you mention IgG, they will consider. And EEG, as I say, are the tests for the SSP. Clinical picture, and therefore somebody may ask you, even further in the Viva also, what are the criteria for diagnosis of SSP? Are there any criteria? What is the name of their criteria? Because I will say drafted these 4 questions, but somebody else or some other examiner may put some other questions. So we should be aware of it. Anybody has answer?
Yes, Daikin criteria.
Yes, Daikin criteria. Who has answer?
Aditi, Dr. Aditi.
Aditi, can you go into details of Daikin's criteria if you have idea?
Aditi, unmute yourself and then answer.
Yeah. If
It's
you are
better.
knowing, it's okay. But if you are not knowing details, no problem. Anyway, let me answer.
Sir,
Yes, Aditi.
Sir, in the Daikin's criteria, one major and two minor criteria. It includes, sir, specific EEG changes and CSF measles antibody
Right.
and sir, neuroimaging. Sorry, I remember this much. Sir.
Okay.
Yeah.
Please remember, I will give you the details. Even I will give some more details of the actually Daikin's criteria. It's a modified. First, it was devised in 1980. Recently, I would say it's not old one. And again, modification was done in 1985. In major, there are only 2 points. So very easy to remember. Major, only 2 points. That is clinical history, which may be even typical and atypical. But clinical history, what already scenario we have given. If it is there, that is suggesting. Second is increased CSF measures antibody titer. These are 2 measures. Please remember, EEG is in the minor criteria, typical EEG. Increased CSF IgG, yes. Then brain biopsy, NUS spatial molecular diagnostic test to identify measles virus mutated genome. Basically the disease is due to the mutated virus, measles virus. And to identify its presence, there is now molecular diagnostic test is also there. For the interpretation, they say either 2 major. If 2 major, it's diagnostic. Or I think here it is something different interpretation compared to other criteria. Or 3 minor out of 5. There are 5 minor criteria, but suppose 3, even the only minor, then also you can consider. Anyway, let me go in detail. What is the prognosis of SSP? What is the prognosis? Somebody is going to ask us, what is the prognosis of SSP? Any idea?
Poor prognosis. Aditi has answered.
What is the, I will say, poor in what sense? Suppose tuberculosis meningitis also with the advanced disease, child may survive, but sequelae will remain. That is the poor prognosis.
Sir, there is neuroregression and sir, there is no specific treatment for it. So neurodevelopmental outcome is poor, sir.
Okay. Once somebody has asked the questions, usually prognosis point of view, in such type of the thing, particularly in the OSCE, the answer will be very precise. We know that the poor prognosis following encephalitis, following tuberculosis, even sometimes bacterial meningitis, suppose maximum brain damage has taken place, we say it's poor. But here, it's a lethal. Invariably, the fatal brain inflammatory disease, it's a ultimately child is not going to survive. And therefore, somebody may ask the question, do you know what are the conditions that are ultimately almost fatal? Almost, that means till even probably hardly surviving has been deported.
Sir, rabies.
One is rabies, very good. Please remember, second, even the SSP. SSP almost comes in the category of rabies. And third, even if you have the name, there is Creutzfeldt-Jakob disease. It's not, these are the slow viruses. Somebody is asking, slow viral CNS infections. Then they are classified in that also. One more point I would like to give the idea that, it is more common somehow in boys than the girls. And therefore, if you see your history here, I started with the 10-year-old boy. To give the message even, suppose in Korea, I will keep that it's a female. SLE, I will try to put it a female because that is most common in the females. So like that, even that may also become one clue for this student which we should know. Anybody know the stages of the SSP? There are certain stages also. And if you are remembering in this way, it helps you for good diagnosis. And even suppose by chance full question is asked, you can. Anybody? Any response, Dr. Lata?
No, sir. No, sir.
Sir,
Yes.
there are 4 stages.
Hmm.
First stage is, sir, there is behavioral decline.
Very good.
There is poor scholastic performance.
Hmm.
In the second stage, sir, there is myoclonic jerks, myoclonic
Right.
seizures.
Yes.
In third stage, sir, there are progressive extrapyramidal symptoms.
Very good.
And in fourth stage, sir, there is coma.
Very good. Almost, I will say, correct answer.
Yeah.
Stage 1 usually presents with behavior, and that for the clinician difficult. And they are non-specific. Some personality changes, irritability, mood swings, very particular decline in school performance. And they say that is due to the cortex involvement. Second part is frequent falls, ataxia, myoclonus, seizures, and that is the involvement of motor part. Particularly spasticity and unconsciousness, that comes as stage 3, and stage 4 is usually called as a terminal, where it may be the vegetative state, coma, or even the death. And they said that during this stage, almost entire CNS is affected. Therefore, SSP is slowly progressive disease, and therefore it is like this. Which is the drug of choice for the myoclonic jerks in SSP? Which is the drug of choice for myoclonic jerks in SSP? Again, this question is asked very purposefully. If somebody is knowing, probably we'll be able to address. And I think in this my OSCE, these questions are there, but now I'm going to add even.
So we have an answer. Yes, sir. Carbamazepine.
Is it? Who has answered?
Nikita Andani.
Okay. Nikita, I think if I remind you, carbamazepine is contraindicated myoclonic epilepsy. Am I right?
Yes, sir.
Nikita?
Yes, sir. Yes, sir.
Then why you said that it is the drug of choice for myoclonic jerks in SSP? You have any idea, or just you have done some mistake? Nikita, what is your idea? Somebody, I will say, cross-checking in the exam. Don't become the nervous.
Sir,
Nikita,
this is the only indication of carbamazepine myoclonic jerk, sir, SSP.
Yeah, that's why I asked the question. And I'm sure that in the exam also such case is there. Examiner is going to ask you. Usually carbamazepine, every place if you see, in myoclonic jerks, it is contrary. On the contrary, it increases. But this is the only condition. Somehow I tried to get the explanation. I didn't get it. Probably some neurologist is knowing. But the carbamazepine is the drug of choice for myoclonic jerks in SSP. So I think this is something different compared to routine. Therefore, we should remember. Are there any drugs for SSP or treatment point of view? Any drugs which people have tried? Any response, Dr. Lata?
No, sir. So Levipir only is the single response.
Okay,
these are the, yes, sir.
I think here treatment that is specific drug for the SSP.
Somebody has answered, sir. Arociplinex.
Yes, very good. What is that? What is that? How it is classified? What I mean to say?
One person has answered interventricular interferon.
Okay. Isoprenosine.
Immunomodulator.
It's an immunomodulator. Good. It's a CNS immunomodulator. Another drug, somebody answered rightly, interferon. They have tried, and even the ribavirin. So these are some antiviral and immunomodulator drugs they have tried. So what was my idea in the SSP, that these type of various questions can be asked, not only the questions which we have framed over here, but you can remember, and if you know, even you can answer some other questions beyond these also.
So we have one question. Our Dr. Sudhakar has asked,
Yes.
Sir, are prions same as slow viruses?
Sorry?
Prions, same as slow viruses?
Sorry, I didn't follow exactly.
Prions. So those infectious having genetic, which do not have genetic material.
Yeah.
Yeah, they are also, I think so.
Yeah, yes.
Yes.
Okay, should we go further?
Yes, sir.
This is the 10-month-old child presented with afebrile encephalopathy for 2 days, followed by vomiting and running nose for a day. His development was normal prior to this illness. The child had frequent dystonia, which was observed on admission. MRI brain showed symmetrical basal ganglia and brainstem. T2 hyper intensifies with diffusion restriction. And magnetic resonance spectroscopy, please remember here, it is a spectroscopy, gave an important etiological clue. See, the 10-month-old child previously absolutely healthy hearty. Following this viral infection, child developed this afebrile encephalopathy. These are the MRI changes and MRS changes. What is the probable diagnosis? If somebody is knowing properly, probably will be able to answer.
So one answer has come.
Yes.
Japanese encephalitis.
Okay.
Two persons have answered Japanese encephalitis.
Okay, good. Why Japanese encephalitis? Any justification? In the OSCE, nobody is going to ask justification, yes or no. But if suppose discussion viva or something, they are going to ask the justification. That which are the points favoring your diagnosis. This is the picture. Japanese encephalitis, if you know, is a febrile encephalitis. It is classified as acute febrile encephalitis. Here it is purposefully, that's why the one important clue is a afebrile. Of course, precipitated by some viral infection. Because development was also normal before this illness. And here the involvement is basal ganglia because dystonia is there. Even the MRI changes are showing. But another point, if you are knowing, magnetic resonance spectroscopy. I think before we go for the discussion, anybody knows what is MRS? What is magnetic resonance spectroscopy? Any idea? Let us, I will say, if you understand, probably we'll understand further also. Not only in this condition, but other conditions also. What is magnetic resonance spectroscopy? What we do and how we interpret and in which conditions it will be useful. Let us wait for some time for responses.
Protein and lipid spikes.
Sorry?
Protein and lipid spikes.
Okay, very good. At least that is having some idea. Anybody can explain? Yes, anybody can explain?
Sir, it is an advanced technique that checks the chemical composition of brain tissues. For example,
Yes.
sir, if there is choline peak, then we can suspect tumors and demyelinating diseases. If there is
Right.
lipid peak, then tuberculosis. So the
Very
chemical
good.
composition.
Very good. Very good. That's the thing. If basic concept, if you remember, I think, maybe the complex phenomenon. some specialist people can, I will say, go for this. But as a clinician, if you have the idea that what exactly the MRS is. So MRS, we know it's a non-invasive diagnostic test. It is performed by MRI machine only. Even I talk to the radiologists, even those who are doing in Ahmedabad, 1 or 2 people are familiar with this, because I think 6 months or 1 year back, I had one of the patient. And then I understood that here, what Aditi was talking, people say it's a chemical biopsy, the word they use. And here they are able to analyze biochemical composition and metabolic activity of some specific area. And then they can differentiate between the healthy and diseased tissues. And from very specific changes, they can diagnose. Even they can say, metabolite substance point of view, very important is N-acetyl aspartate. One other is choline, what Aditi was mentioning, even lactate, creatine. So these type of the very specific some changes they can decide. And particularly suppose there is a very specific parts of the brain are affected, then they can correlate. And they are able to diagnose from these, what Aditi was telling us, even the tuberculous meningitis, they can differentiate, even the brain tumors, neurometabolic disorders, even in muscles and liver also, they are using the MRS. So in short, that is the condition. And now, if you have the idea, then what is the likely condition? At least you can categorize. Suppose you are not able to exact name the condition, what type of disorder is likely?
Sir, mitochondrial encephalopathies can.
Very good. Yes. This is very specifically mitochondrial encephalopathy. Then my next question is going to be, what are the mitochondrial disorders you know? What are the mitochondrial disorders?
Sir, Melas,
Melas is most common, which probably frequently all of us have heard the name. That is the mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. I think in last our Tuesday case only the stroke-like, and we had this discussion regarding the Melas. Another, any mitochondrial disorder if you are knowing, Aditi or?
Sir, Murph.
Yes,
Murph and Legs disease, Leys syndrome.
Yes, Leys syndrome. Then if you are knowing the details of Leys, you'll be able to answer. Leys is usually present in the youngsters. Precipitation by viral infection is common. And these type, the rest of the things, MRI findings and MRS findings. So I think now the answer should be easy. It's a Leys disease. Then what is the expected MRS findings? Already probably we have discussed in detail. Let me put the answer. It's called a double inverted lactate peak. You know, it is just like the graphic, you will get it. And here double inverted that means a negative. And some lactate peak you can. I think maybe the complex for us to understand being clinician, but they interpret double inverted lactate peak. What is the confirmatory test? Suppose Leys from this even MRS and clinical picture if you are suspecting.
Genomic sequencing, sir.
Exactly. We have to go for at nowadays, and you know, the genetic testing is confirmatory. And now several conditions were able to have. What treatment you can offer? What treatment you can offer?
Sir, supportive treatment like dystonia for drugs.
Okay.
For dystonia.
Right. And specific for the Leys, you know, most of the times in neurometabolic, we are going for supportive. That suppose even this something excess, you can try to decrease. Suppose ammonia, you can decrease. Some of the conditions, I will give you example, not necessary for Leys syndrome. Or some deficit, you can supplement. Or some symptomatic, as already said, for the dystonia. Like that, what treatment you can offer for the Leys syndrome? or less disease. Please remember very specific, one of them is the vitamin. Which vitamin? In supportive therapy, one vitamin is specific particular for the less disease.
Answered B6, biotin. Two answers.
Okay, biotin. Biotin is
Dr.
for.
Shivani has also entered biotin and thymine.
Who mentioned the thymine?
Dr. Shivani.
Okay, fine. You know that, as I said, mitochondrial cocktail drugs usually we give. Supportive, that is the carnitine, riboflavin, biotin, etc. Every answer is right. But thiamine, it is said the very specific treatment for the less disease is a thiamine. And yes, for dystonia, what Aditi mentioned, that even trihexyphenidyl, physiotherapy and stimulation. So these are the points for the diagnosis. I think somebody may ask even the double inverted lactate peak on MRS, because these are the even you have one paper for advancement in the medicine. So all these points you can remember, which will be useful. Let us go further. A 2.5 years old male child born to third-degree consanguineous parents presented with encephalopathy and seizures. His development was delayed. Perinatal period was normal. That means no any insult, no asphyxia. And on examination, alopecia, seborrheic dermatitis were obvious finding. He lost his elder sibling at 7 months of age due to similar illness and refractory seizures. HIV was negative. What is the likely diagnosis?
Already answers are coming.
Yes.
Dr. Nikita has said biotin deficiency.
Right. Dr. Ankita had mentioned?
Nikhila Reddy. And
okay.
I think Aditi has also answered. No, Aditi.
Nikhila, okay. Multiple students. Please remember, this is common even, I would say, metabolic disorder. And answer is right. It's a biotinidase deficiency. Please remember the enzyme. Biotinidase enzyme deficiency. What is the mode of inheritance? I think if you don't know, but then also if you know the clue which is given in the history.
Autosomal recessive inheritance.
Yeah, why autosomal recessive? Because consanguineous one clue is given most of the times. Okay, what investigations would confirm the diagnosis? Easy. Deficiency that will confirm. So biotinidase estimation. And even genetic testing will be confirmatory. Treatment, very simple, biotin. Anybody has given the biotin supplementation? That what strength tablet is available, what it cost? Anything? Anybody knows?
Still not sick.
Whether liquid is available. Because these questions, suppose if I am exam, I will ask because I know whether the person has used or not. Biotin is not available in liquid form, it is tablet. 10 milligram tablet is available, probably 40 also. Very cheap. It is very cheap and really very good response to the biotin in this type of situation. If you are knowing, I'm sure that you will get the patients.
So Dr. Srinivas answered biotin 10 mg.
Yeah. Is there any risk of recurrence of this disorder in the next pregnancy? Autosomal recessive. So, even in an OSCE, good examiners will some important clues in the history, story, previous question. So, you can answer this question very easily if you don't know then also. Is there any risk of recurrence?
So, Dr. Jayas Jagan has answered 25%.
Yeah, because it is autosomal recessive. If you are knowing the principle, yes, 25% in each pregnancy. Better to specify in each pregnancy. Good. Let us go further. 6-year-old boy was brought in the OPD by parents after teachers complained of episodes of studying in the classroom and occasionally drop a pencil. EEG image was as below. I think very simple question and very common one. What is the answer? Probably.
Answer has already come.
Absent seizures.
Seizures.
Okay.
Everybody is answering.
But you know, the better to know this EEG interpretation, diagnosis is absence epilepsy, absence seizures. Please remember some of the types. To save the time I go, it's a typical, atypical, juvenile. And something different. Typical absence occurs in childhood. Atypical occurs in Lennox-Gastaut syndrome. I think that also will see the case. I hope that you know the syndrome. In Lennox-Gastaut syndrome, sometimes presentation is absence seizure, and then it is diagnosed. But suppose if it is the neuroregression, immediately you can think that it is Lennox-Gastaut. Even juvenile occasionally, and later on in juvenile myoclonic epilepsy. Here, because the drug choice may change if you categorize. If this type of seizure occurs in toddler age group, which disease should be ruled out? Already it was answered in my discussion. Toddler,
ASD.
Sorry?
Dr. Srinivas has answered ASD. Autism.
Yeah. That is even the glucose transport 1 deficiency. It's a Lennox-Gastaut variety. And what drug should be used for absence seizure?
Ethosuximide.
Okay. Second, ethosuximide may not be easily available, but it is the drug of choice, number 1 drug. But which is another drug which is very commonly available and we are using?
Valproate. Some people are answering valproate.
Yeah. Please remember these 2 drugs. Ethosuximide and sodium valproate. Other drugs in the absence seizures is not I will say helpful. So ethosuximide is the drug of choice, number 1, but easy to get it, and therefore sodium valproate can be used. And sometimes the people say, may start with the absence seizure and then become the generalized tonic-clonic. And therefore somebody is from the beginning sodium valproate, probably that future progression can be prevented. So that's the reason. What drug should be avoided in this disorder? Because commonly the people are, sometimes if you are not aware, they will prescribe. Therefore the question is that which drugs should be avoided in this disorder? Yes, anybody?
No answer. Sir, carbamazepine. Somebody is answering. Carbamazepine,
I think for contraindication, if you remember, for contraindication, somebody is asking in epilepsy, carbamazepine, phenytoin, and sometimes even the levetrizine. These are the 3 drugs. So where specific condition they are contraindicated. So carbamazepine and phenytoin. On the contrary, if somebody has prescribed, the episodes will increase. And suppose if you get even this type of story, that episodes are increasing following the drugs, even neurologists say that there is no need to go for further confirmation. Which is the bedside provocative test favoring the diagnosis?
Hyperventilation.
Very good. I am not prepared, but some, another, I will give the idea that they will put the video and then they will ask these kind of questions. So that we should know hyperventilation. I think I will try to get the video so that even that may be the another way of putting this type of OSCE. Okay, here is a 10-month-old infant is brought by the parents with complaints of multiple episodes of sudden forward bending of body, arms and legs for a few seconds, followed by a pause of 5 to 10 seconds, and followed by similar episodes of clusters. EG was as below. Read each, I will say.
Infantile spasms, sir. Arrhythmia.
Yes, who is answering?
So Nikita, Dr. Nikita.
Yes, Nikita.
And so many persons have answered infantile spasm, syndrome, hips arrhythmia. These are the
Right.
answers. Dr. Prachi, Dr. Srinivas.
Very good. Let us go. What they mention. Identify the EG abnormality. And EG absurdity, hips arrhythmia. What do you mean by hips arrhythmia? Because hips arrhythmia is not the specific diagnosis for one condition, but it's a very classical EG findings. And very few conditions will be there. According to the clinical picture, you can consider the possibility. Here is the chaotic mixture of asynchronous, very high voltage, polymorphic delta, slowing, and multifocal spikes. As I said, I may not be helpful for EG. What is the diagnosis already given? It is the West syndrome. It is the West syndrome or East syndrome. Why the West syndrome name is given? Why not the East? Was it diagnosed in the West?
Scientist's name, Dr. Srinivas has answered.
Yes. Who was the scientist? Very good. Anybody
James
knows?
West.
Yes.
West.
Anybody knows regarding the West syndrome in something details? This is interesting. That's why I'm asking.
He diagnosed it is this syndrome in his own son, sir.
Yes, very good. In his own son. And then what is the another name of this West syndrome? Is there another name?
Infantile spasm, somebody has answered.
Infantile spasm, yes, another name. Further.
Infantile epileptic spasm syndrome.
Okay. I think smart person can make the smart answer. Because examiner cannot say no, but
Salam attack.
yes.
Salam Caesar, somebody.
Salam or salutation type seizures. Another name actually, why I'm giving these names and somebody may consider. Let me take a minute even. Actually, this was, as Aditi said, it was diagnosed in the boy, I will say, of this Mr. West. He was from, I would say, some town in England. And he was not sure what it is. And therefore, he wrote a letter to the editor of Lancet describing this very specific picture of the illness in his son. And then he was not sure that what it is. Later on, so many people even worked out, and even one of the persons say it's an infantile myoclonic encephalopathy with hips arrhythmia. Gestalt. Lennox-Gastaut syndrome, what we say, that Gastaut put it is a myoclonic encephalopathy with hips arrhythmia. That name was given. Then from some Germany neurologist, he said it is like Salam. And ultimately they said that the name should be kept on the name of the person whose son suffered. And therefore ultimately it was named as West syndrome. This is a little bit story of the history, but I'm sure it is interesting. Somebody may ask you, what are the clinical manifestations? And I will say these syndromes are not uncommon in the practice. You may not get so frequently, but yes, we do come across. What are the clinical manifestations? I think already have discussed.
Yes, sir. Dr. Srinivas has answered spasms and global developmental delay.
Very good, very good. Please, infantile spasms, and if you are not sure, but if that is with a delayed development or sometimes regression.
Regression.
This is very classical story. And if you get the hips arrhythmia on EG, therefore, please remember, some people may ask, what is the triad of diagnosis of this West syndrome? Then infantile spasm, mental retardation, and hips arrhythmia. This is the triad for the diagnosis. Treatment, very important. What treatment should be given?
ACTH, Dr. Devanshi Rana has answered. Dr. Srinivas, Zoom user, everybody has Tikita, everybody has answered ACTH.
Okay.
Prednisolone by Dr. Srinivas.
Okay. Anything else?
No, so steroid and ACTH by Dr. Jagan. Vigabatrin by Dr. Srinivas.
Yes, Vigabatrin in which type of in any patient or any specific?
In tuberous sclerosis.
Very good. Very good.
Answer.
Commonly, we go for the injection ACTH or even the steroid, that is prednisolone, oral. And if it is associated with tuberous sclerosis, Vigabatrin, I think Sabril is the name, trade name available, Vigabatrin. It is sometimes difficult to get, but it is available. And this, with the tuberous sclerosis, this West syndrome or the infantile spasm is commonly associated. CNS point of view. Somebody may ask you the question in that way also. In the tuberous sclerosis scenario, they will give and then they will ask the question. So here the Vigabatrin is the drug of choice. That particularly the description, what we say that the fraction of head and the trunk and the limbs, what do you call it? Somebody may give the picture or the video and they will ask that describe this particular posture of this child. Is there any specific name of the posture? Will you follow my question? I think if you go the description, you will understand. What is the description? Multiple episodes, sudden forward bending, then arms and legs will flex. What is the name of this posture or position?
So they have answered salam spells.
Okay. Posture, but
jackknife posture.
In salam, what happens? That is the only fraction of head that we say salam. But here as a whole, that salam, then this fraction of even the trunk and then limbs. I think that best way, if I have shown the video, that comes to your mind.
So Dr. Devanshi Rana has answered jackknife posture.
Okay. If I give the idea, let me give the idea. What is the, I will say, posture in a case of tetanus sometimes? Very bad spasm. Then what posture develops in a case of tetanus? Sometimes even I will say GRD.
Opisthetonos.
Opisthetonos. What is the opposite to the opisthetonos?
Opposite.
This is opposite to that. I'm sure that everybody may not heard the name, but opposite to opisthetonos. In opisthetonos, there's the arching of back, and like Dhanush, that's why even it describe it like Dhanush in tetanus. But here there is a fraction of the trunk.
Emprosthetonos.
Yes. Please remember the terminology. It's a emprosthetonos. Opisthetonos opposite is the emprosthetonos. So this posture is the emprosthetonos. Somebody will put the OSCE with the video and they will ask that they name this posture of this child. So, I am giving the idea that there may be the different ways of putting the questions, framing the questions in the exam. Okay. Let us go further. A 4-year-old boy presented with status epilepticus in emergency. He also has cognitive issues and behavioral problems. The child had first seizures at 4 months of age following vaccination. Later on, he had fever, provoked focal seizures frequently, and generalized tonic-clonic seizures after 2 years of age. Now, yes, the seizures once in every 2 to 3 months started to share unprovoked seizures after 2.5 years, along with even the fever provoked. That means fever provoked or without even the provocation. He also develops intermittent brief blank episodes lasting for few seconds. Perinatal period was totally normal. MRI brain is normal. Please go into details, and if you are knowing, this is not I will say uncommon scenario which I have given.
So we are already having answers.
Okay.
Should I ready to read it?
What is the answer?
Dr. Nikita Reddy has answered Dravet syndrome. Dr. Shaunak, Dravet syndrome.
Sorry, what is the spelling?
Dravet syndrome.
Okay. Fine. Let me see what are the questions framed over here. Question and answer, both you got it in one click. That is the Dravet syndrome. And I think that's good. Best compliments, I will say, to the responders. What is the most common gene implicated in this condition? It's a very specific question, difficult to remember, but the people now, I even before framing this question, I checked that yes, the OSCE they are asking. So I thought that I should sensitize you by putting such questions. There is some specific conditions, they put even the gene as a question. So they frame it. Anybody?
We have so many answers, right? Dr. Nikita, then Dr. Devanshi, Shaunak.
That's good.
Everybody has answered SC1A. SC and 1A. Sorry.
Very good. I think they are definitely well prepared for the exam. What is the most common pattern of inheritance? Dravet syndrome, what is the most common pattern of inheritance?
Autosomal recessive. Dr. Prachi, Dr. Nikita, Dr. Pallavi answered autosomal dominant. Dr. Devanshi answered.
I would say now you can decide by yourself who is right and wrong.
Sir, autosomal
dominant.
Dominant is second.
What anticonvulsant drugs are used to control the seizures in this condition? What anticonvulsant drugs are used to control the seizures in this condition?
So Dr. Shaunak has answered clonazepam.
Clonazepam.
Valproic acid, Dr. Devanshi.
Okay.
Stirpentol by Dr. Srinivas.
Right. Let us see the answer. Sodium valproate, yes. Clobazam, that as a whole, I will say clonazepam, clobazam, if you put, may not be wrong. Even levetiracetam should be used. Please remember again here, carbamazepine, phenytoin should be avoided. I think yes, the question is there. Which anticonvulsant drugs to be avoided in this disease? Phenytoin, carbamazepine, lamotrigine. Whenever the question comes of avoidance in the epilepsy, probably these three drugs, they are very specific in very specific varieties of epilepsy will be useful. Otherwise, they will be problematic. So phenytoin, carbamazepine, and lamotrigine should be avoided. I think before I go for this question, if I am there in the Viva, I will ask him this question. Why not it is the febrile seizure? Simple. If I give the scenario. Or in other way, if I ask the question, how the Nelson has classified this condition, Dravet syndrome, in 22nd edition, recent edition. Dravet syndrome name is from the person. And you know, that was also recently, I will say, not old one, 78 only. And the name given to this is so recent, Dravet syndrome, is 1989, because when we were studying, even this name was not existent. Not even Dravet, as a whole the condition. I will say it's a simple febrile seizures. Is it right?
Dr. Nikita has answered classified as ITIS.
Okay.
Sir, developmental and epileptic encephalopathies, Nelson.
Yeah.
Developmental encephalopathy.
Yeah. Please remember this condition because it has raised so many issues. That's why I brought this point. In, I will say, conference also we have discussed some examiners, suppose if you knowing, may go in the details. Actually, it is the phenotypically. That means, if you see the presentation, just if you don't go details anything, phenotypically, it's a febrile seizure. Spectrum of the febrile seizure. Later on goes for the epilepsy. It is classified in this way. And therefore, interesting story. This is very distinct entity, variety of epilepsy, which presents in the infancy. Initially, it was characterized by febrile and afebrile unilateral chronic seizures, recurring even. And that's why, here recurrences are very characteristic, which given in the scenario also. But point is, many points are there that it is the more prolonged, goes for the status. Sometimes maybe the focal. And the following the vaccine, particularly with the DPT vaccine, what we used to understand, it's a post-vaccine, particularly the post-pertussis encephalopathy. People now say with the genetic study that many of them were Dravet syndrome and not the pertussis encephalopathy. If you read the recent articles, or even I think of Nelson also I checked, they have put it that the vaccine encephalopathy is now question mark. Probably that type of the entity may not be there. If you go from this genetic study of this type of the presentation, commonly following the vaccine was encephalopathy develops. They are Dravet syndrome. So that's, I will say, something to bring to your notice. And particularly the important point that, and even if somebody asks me, at my own place, even the practice, I have seen 2 or 3 patients that following the DPT, full cell we were using in the past, I'm talking of 20-25 years back, and then encephalopathy, and then even they remain with some sequelae, which there is a part of encephalopathy. But now we realize that probably following even this article and Nelson, that many of them may be the Dravet syndrome. So try to understand that Dravet syndrome and the vaccine encephalopathy, this entity, how they differ, and how with the genetic study it has added to our knowledge. Anyway, let us go further. That's why I thought that I will not just go through 4 or 5 questions of the OSCE, because somebody may put the question as I put, but other examiners may have their own way. And if you cover the whole topic, probably for the students, they will not face the problem. Now here, it's a 4-year-old boy presented with the delayed development, multiple seizures in the form of vacant stares and sudden jerks, recurrent head drops and falls. It's a 4-year-old boy. If you note it, delayed development, multiple seizures, description, vacant stares and sudden jerk. What do you call it? And then recurrent head drops and falls. And this is they have tried to show EEG changes.
Sir, Lennox Chestot.
Okay, let me see. Aditi is
Yes,
answering.
Dr. Devanshi. Yes, sir.
Okay.
Dr. Devanshi Rana has answered Linux Chestot. Nikita
Okay.
Reddy, NS Chestot. Vejugam Omnivas has answered atypical absence seizures.
Okay, good.
Dr. Srinivas has also answered atypical absence seizures.
I think
So
we are in the democratic country, so we'll have to follow the majority. Whether right or wrong. But here it is right. It's a Lennox Gestalt syndrome. And Gestalt, which I was talking for the West, who contributed, is this person, Leonard Gestalt. He also said that let us go for the naming the West syndrome. And what is the triad of this condition? In absence that I think the person will answer, usually there will not be the delayed development or mental retardation. Triad is, this is a triad, psychomotor delay or regression, refractory multiple. You know, Lennox Gestalt, difficult to control the seizures if you ask any neurologist. And classical EEG. That means regression or delayed development, refractory multiple seizures, and classical EEG changes. Very simple question. I think after these complex conditions, a 4-year-old child presented with right focal seizures. Port wine strain was noted on the left side of the face. If you note it, seizures on the right side, port wine strain on the left side.
Answers have started coming.
Question, probable diagnosis.
Sturge-Weber, most of them has answered Sturge-Weber.
Very good. Sturge-Weber. And Sturge-Weber, I will say it's a common question is going to be that either CT scan they will put this as a scenario, or even some skin lesions they will show, and then they will start the story. So it's a Sturge-Weber. What is the triad? What is these 3 things which will be very characteristic of Sturge-Weber?
Glaucoma delay.
Okay. Very good. You know, one is the skin lesion. That is very classical. And therefore, even if you just routinely the patient has come to you with some other complaint or even the vaccination, if you got this port wine stain, don't wait for the seizures. And therefore, port wine stain, particularly which area? In the characteristic of the port wine nevus, leptomeningeal angiomatosis and glaucoma. And even somebody say epilepsy type. What is the common anatomical situation of the port wine stain which I was asking on the face?
Ophthalmic division of the trigeminal nerve distribution.
Yeah, please remember, it's an ophthalmic division of the, and therefore nearby eye. If you get you on the spot, keep in mind, is it really Sturge-Weber or not? How do you confirm the diagnosis? What you will get in some other, or what investigations you may perform?
CT brain.
Neuroimaging, yes. MRI brain with
MRI
contrast.
brain.
And
CT tram track classification.
Yes, or even the CT scan, what you are going to get it?
Tram track appearance.
Very classical, yes. Tram track calcifications. It's a tram track. So first we'll have to see the tram. Then we'll have to see the track on which the tram is running. That type of calcification with even unihemispheric atrophy. And sometimes if suppose intractable seizures, here somebody is even the advice for the surgery. What are the other neurological manifestations of this disease? Other neurological manifestations of this disease?
Epilepsy, Dr. Srinivasa's answer.
Yes, very good. Anything else? Please, there may be even sometimes hemiparesis, transient ischemic attacks, even headache. Though these type of the manifestations can be there in the surgery. Every time may not be having even the classical picture of even the, may not be the seizures sometimes, that's transient ischemic attacks, headache. Anyway, let us go further. 3-year-old girl was diagnosed as autism. detailed history revealed her development normal till 10 months of age. Then gradually started to develop cognition regression, autistic features, and loss of purposeful hand movements, and even the abnormal gait. And some clinician noted that she had macrocephaly. Please try to go in the details. 3-year-old girl diagnosed as autism. Later on, they got the more details. The development was normal till 10 months of age, but then gradually started to develop cognition regression, autistic features, loss of these hand movements, even abnormal gait, and macrocephaly. What is the probable diagnosis?
We are already having answers.
Oh,
5
very
people
good.
have answered Rett syndrome. Dr.
Very
Aditi,
good,
Dr.
very good.
Devanshi, Srinivas, some Zoom user.
Fantastic. I think they are well prepared for the exam. Yes. Very classical feature of Rett syndrome. It is said, that's why I prepared even this OSCE when I was attending one of the neurological conference. That most of the times the neurologists, they are getting the Rett syndrome because pediatrician is diagnosed as autism. And after some time, with these more issues, but he said that any child with the autistic spectrum disorders, having either the macrocephaly, because macrocephaly will be before any manifestation, and later on regression or something, always go for the suspicious of Rett syndrome. What is the most common pattern of inheritance? Pattern of inheritance of the disease?
X-linked dominant. Dr. Nikita Reddy,
Very good. Very good.
Srinivas, Dr. Devanshi.
Yes, it is
Aditi.
X-linked dominant, yes. What is the most common gene implicated in this condition? This is difficult.
Already you are getting answer. MECP2.
क्या बात है?
Yes, everybody is so fast, sir. Before you finish a question,
I think very good, very good. Very good. What is the common cause of death in this disease? What is the common cause for death in the Rett syndrome?
Cardiac arrhythmia. Dr. Nikita has answered.
Okay, then I can't say no.
Cardiovascular.
Yes, it is cardiac arrhythmia. Cardiac arrhythmia is a cause of death in the Rett syndrome. Good, I think they responded very nicely. Very good.
Yeah.
Let us go further now. A 5-year-old boy presented with neuroregression, stopped walking, standing and sitting even gradually. Non-ambulatory by 4 years of age. His development was normal till 2 years of age. On examination, spasticity and pyramidal signs were noted, but ankle jerk was diminished. No seizures. And this was the MRI picture. First question will be, what does the MRI picture show? That's why I'm keeping this picture even. If you are accustomed to some common conditions, you can answer. Yes, what is the interpretation of MRI brain?
Racing car. Dr. Srinivas has answered.
What is the answer?
Racing car, leukodystrophy. Some
Okay.
person answered leukodystrophy.
Very good. MRI findings point of view, it's a symmetrical periventricular white matter, T2 hyper intensities, sparing the subcortical fibers. I think if I go back, which I try to understand even from the neurology, this is the periventricular hyperintensities. But subcortical, these fibers are spared. And there is very classical picture of diagnosis.
Metachromatic leukodystrophy. Somebody's answered.
Metachromatic leukodystrophy is correct answer. What is the enzyme deficient in this condition? What is the very specific enzyme deficiency? Anybody?
Aryl sulfatase A.
Yes, aryl sulfatase is good. Aryl sulfatase A. And what is the mode of inheritance? Here, if you know in the OSCE, answer should be very specific. If you are knowing the enzyme, you will correct answer. Otherwise, no. But just by knowing the name, you will not get the marks. Mode of inheritance?
Autosomal recessive.
Yes, it is autosomal recessive. Yes. One more question. What is the explanation for diminished ankle jerk? Because, otherwise there is the pyramidal tract involvement, even spasticity, hypertonia, and why the ankle jerk is diminished. I will say in any neurology, if you remember the basics, that when even in spite of this hypertonia, when the DTR diminishes, what is the probable explanation? Which is most of the conditions it is right. If you are knowing the basic principle.
So Zoom user has answered pyramidal tract involvement.
Pyramidal tract involvement, we are expecting DTR exaggerated.
PNS, peripheral nervous system involvement is.
Yeah, this is due to the peripheral neuropathy. And here, this metachromatic leukodystrophy, basically it's a white matter disorder. Later on, it goes for the gray matter involvement. And if I recollect, I think I saw the metachromatic leukodystrophy in 1983. I will say more than 40 years back. I remember 8 years old girl from Surendranagar. Very classical picture that she was not able to walk. And spasticity and diminished. We were not sure that what is the disease. I remember Dr. Hemsegal Madam even. Name I remember. She was in our department from Delhi. Her interest was pediatric neurologist during that time. And she said that this is the metachromatic leukodystrophy. She asked during that time, go for the sural nerve biopsy. And even she said that if somebody is doing, you can go for the enzyme estimation. During that time, I'm talking of 83. And somehow I don't remember with the biopsy or something, but that was the first case in our department. We got the metachromatic leukodystrophy. And nowadays, that so many things are possible for the diagnosis. So ankle jerk diminished due to peripheral neuropathy. It is said that in any type of the upper motor neuron type of lesion, if the deep tendon reflexes, particularly deep tendon reflexes, all others may not be affected. But ankle jerk very classically will be the diminished. And that is the explanation of the peripheral neuropathy. What is the risk of recurrence? Already you have probably answered autosomal recessive. So 25% in each pregnancy. Let us go further. 18 months old male child present with regression in developmental milestones since 10 months of age. And cognition regression since 1 year of age. Child had severe pallor, hypopigmented sparse hairs, hyperpigmented knuckles. He was predominantly breastfed only. I think very classical picture, not uncommon in India, and everybody should know. What is the probable diagnosis?
Then we have all the answers. B12 deficiency, ITS.
Yes, it is the infantile tremor or anemia tremor syndrome. Very classical, it is said, even very, very serious presentations I have seen. One of in our case discussion, I think somebody was from Nagpur. I know probably Dr. Girish. He's a very good clinician. He brought the case. With the regression, everything you will find that this is a neurometabolic disorder. And there was the generalized hyperpigmentation rather than the knuckle. And they went, even the mother's investigations, she was deficit with B12. And it is said that in India, when this mother is even herself is having this deficit and giving the prolonged breastfeeding without even the proper supplementary or complementary feeds, they'll develop even the severe mania. And here, infantile tremor syndrome, usually prognosis is good, but sometimes even it may cause damage to the brain. So that is the very important condition which we should. Sometimes they will put you in the picture also, child's picture, clinical picture. What are the clinical features? I think known to all of you. The tremor, cries, tremulous. Why there is a tremulous cry? There is the bleating of a goat. Anybody can explain what is why the cry is tremulous? Any answer, Dr. Lata?
No, sir.
I think you are able to understand what is the cry tremulous. That means better to listen this when the goat is doing the bleating. Here the child has tremors. And cries tremulous. That means there is a tremor of the vocal cords also. So tremors of the vocal cords gives this cry tremulous. That is very characteristic. I remember some of the teachers, even Dr. Srinivasan from Pondicherry, that from only the cry you can say even with this rest of the pictures. What hematological abnormalities are commonly detected in this disorder? All of you know? Hematological problem? Any response?
Hypersegmented neutrophils.
Okay, very good.
Megaloblasts.
It is a macrocytic.
Macrocytic anemia.
Very important.
Bicytopenia.
Yeah. Because it's a iron deficiency as well as B12 and folic. And hypersegmented neutrophils make a peripheral sphere examination. What is the treatment of this disease? And you know that non-specific we consider exactly the etiology still we have not decided, but commonly yes, B12, iron, folic acid, zinc, magnesium, and good complementary feeds. Actually, that is also the history of this disease, infantile tremor. First, it was diagnosed in India, probably by Dr. Pohowala in Indore. He was the first person to identify that this is something different entity. And then so many people, somebody said it's a post-viral meningoencephalitis, somebody said it is zinc deficiency, magnesium deficiency, somebody said it is the part of malnutrition. So many people contributed with the different names, and ultimately we came to the conclusion it is the infantile tremor syndrome. One more. 10-month-old male child presented with delayed head control, vision impairment, and epileptic spasms. Child had macrocephaly and central hypotonia. Fundus examination revealed optic atrophy. And this is MRI picture. Very classical picture. 10 months old male, delayed specifically the head control, vision impairment. What does it indicate, the vision impairment? Anybody? That will become the important clue.
So we are getting straight away answers. Canavan disease.
Somebody will say that don't go in the details of the discussion.
Yeah, just give the diagnosis.
But the question is different. What is the interpretation of MRI brain? That happens in the OSCE. You are knowing the diagnosis, but you don't know the answer of the questions given in the OSCE. It happens many times. You are able to, you know everything regarding the condition. But they will frame the questions which probably you may not be able to answer. That's why you should know the question.
Yes, sir. So we have few answers.
Mhm.
Optic tract involvement, tigeroid appearance, diffuse white matter involvement, and white matter hyperintensities. So these are our answers.
It is diffuse symmetrical white matter hyperintensity. Good. With prominent subcortical U fiber. I think subcortical fibers are involved. That is very characteristic.
Yeah.
Diagnosis already, as you said, it is given. Canavan's disease. What is the enzyme deficit? Deficiency of which enzyme? In Canavan's disease. Anybody?
Yes, yes. Aspartoacylase enzyme.
Yes. Aspartoacylase. ASP, I think if you write, even somebody will give the marks if you don't remember the details. Mode of inheritance. What is the mode of inheritance?
Autosomal recessive, everybody's answering.
Okay. And what classical finding is expected in MR spectroscopy in this patient? As I was talking, the MR spectroscopy is useful in some brain tumors, tuberculosis, even the neuroregression disorders, SSP, these type of the conditions, even mitochondrial disorder, sorry, not in SSP, this type of the disorder. So what we are expecting in magnetic resonance spectroscopy of brain of this condition?
We have answers, sir. Elevated NA and style aspartate.
Very good.
And 4% have answered.
Substances we discussed 3 or 4. One is the N-acetyl aspartate, very commonly involved in this MRS, what they are able to identify. Another is the choline. Third is the creatine. And I think there was some fourth one also. Lactic acid, yes, common.
Lactic acid.
So from these, and in the MRS, I learned from the radiologist, that they cannot do the whole brain. They focus some specific areas. And some specific areas they can focus and they can go for this type of changes. So I think it is quite interesting and advancement which we should know. Further, 15-month-old child present with motor and cognitive neuroregression since 8 months of age. He also had seizures and vision regression since 10 months of age, along with progressive hyperdystonia. Parents noted exaggerated response to noise. This is very important clue, if you are knowing. And there was no organomegaly. If you see, again, try to understand every word, 15 months old child with motor and cognitive neuroregression. It's a neuroregression. Even the seizures were also there. Vision problem is there. Dystonia is there. And very important clue, among all these different conditions, exaggerated response to the noise without organomegaly. So classical picture is given. Probable diagnosis?
We have an answer by Dr. Aditi. GM1 gangliosidosis, startle response.
Right.
I think Dr. Devanshi is answering Tay-Sachs disease, Bejugan,
Yes.
Sanfilippo. So we have no democracy here, sir. Everybody is answering differently. Niemann-Pick disease by Dr. Shanak.
No, correct. In Niemann-Pick disease, we are expecting organomegaly. Here it is a very classical picture of Tay-Sachs disease. Now, I am not sure whether I put the question or not, but in Tay-Sachs disease, what you are expecting in fundus examination? What you are expecting in fundus examination?
Cherry red spot. Several good answers.
What is it?
Cherry red spots they are answering.
Okay. Somebody will put, I will say, OSCE in some other way. I have the OSCE on the ophthalmology. Then somebody will put here the ophthalmology, that cherry red spot, and then they will ask the question. So this will maybe the another way of preparing the OSCE. So cherry red spot. Now in the cherry red, that color is due to what? In cherry red spot, that red spot which is like cherry, it is red. It is due to what?
Normal fundus. Dr. Nikhila Reddy has answered.
Then what? How it happens so that?
Hemorrhage. Dr. Zoom user has written hemorrhage.
Okay.
Normal spot and surrounding edema. Dr. Devanshi Ram has answered.
If you say hemorrhage and Nikhila said normal, then I think it is contradicting. It is contradicting.
Sir, there is retinal edema due to ganglioside deposition, which causes fovea to look bright.
Okay. Basically what happens in the cherry red spot, that the red spot which we are getting on the examination, somebody very rightly said it's a normal appearance. But surrounding to that is the abnormality or pathology. Surrounding should also be red, but it has become white due to the deposition of this particular substance in the Tay-Sachs disease. Therefore, due to the surrounding deposition of the substance, which is normally it should be red color, has got now the white appearance, and therefore the spot like normal cherry red appearance is seen, what we say cherry red spot. So somebody may ask even how it appears also. Fundus examination, okay, already cherry red spot we discussed. What is the enzyme deficiency in Tay-Sachs disease? I have seen one patient, I will say from Mehsana, almost 10 years back. Very classical. And cherry red spot was diagnosed by one of the ophthalmologists in Ahmedabad, Dr. Rohit Desai.
Hexosaminidase A. Hexosaminidase A.
Very good. Hexosaminidase A enzyme deficiency. I remember that we confirmed from Gangaram Hospital, Delhi. And this is the enzyme deficiency. What is the mode of inheritance of Tay-Sachs? Tay-Sachs is classification point of view. It's a neuroregressive disorder, neurodegenerative disorder. And it is basically the gray matter disorder. Now, what is the mode of inheritance?
Autosomal recessive.
Autosomal recessive, yeah. So somebody may ask, as I was talking even, as a whole neurodegenerative disorders. Then we'll have to go for the classification, that what is the first defined neurodegenerative disorder, white matter, gray matter, and then the mix. Progressively, it starts with the gray or white matter. Later on, ultimately, both the materials are going to be involved. And then when the advanced case, it becomes a difficult that what type of the issues are involved. But if you know the history, that how it started, that will become the important clue that what type of the disorder it is likely, and then you can go for confirmation by the various tests. Nowadays, all the facilities available, even from genetic testing, you can go. 9-month-old child presented with delayed head control, neuroregression, officer posturing, and huge splenomegaly. What is the proper diagnosis? Anybody? Go in the details. Delayed head control, then neuroregression. Now the opposite of the posturing is there. And spleen is
We have
used.
an answer. Culture.
Okay.
Culture disease.
So we can't say no. It's infantile Gaucher. You know, Gaucher disease can present at different ages. This is the infantile variety. Sometimes in older childhood and even the adolescent variety is also there. What is the enzyme deficiency? This is very specific question, and answer should be very specific to get the score. Anybody?
We have one answer only. Glucocerebrosidase.
It is beta glucocerebrosidase deficiency. Beta glucocerebrosidase deficiency. What are the types as I was talking? One is the non-neuropathic, acute neuropathy, and even chronic neuropathy. I think now they are classified in a different way, presenting different age. Confirmation. How will you confirm? Very easy. Already we discussed. You know, that's why in the OSCE, sometimes if you look at the question, you will get even some important clues given. Enzyme average estimation. And genetic testing. What is the mode of inheritance again?
Yeah.
Autonomous recessive. Yes. I think we have crossed 10:30, Lata.
Yes, sir, we have.
Okay, I think we'll go one or two and then we'll stop here, right?
Okay.
This is sometimes they give this type of image. This is the MRI image. Some arrow is shown so that you can even think that where is the problem. Spot diagnosis.
Laryngomyelocele.
Yes. It's the lumbosacral. Better to answer properly.
Lumbosacral.
Because you know, meningomyelocele can occur even sometimes in cervical region also. It's not so common. Common is lumbosacral. Okay. What are the risk factors to develop? Already answer has also come. Folic acid deficiency, most common, all of you know. Even these are the drugs given to the mother, which are antagonist folic acid, can also lead to this condition. What are the indications and timing of surgery? Any idea? To save the time, into ruptured sac with CSF leak, then immediate surgery. And other meningomyelocele can be planned in the first few days of life. But the very emergency that even within few hours we should submit the patient for surgery, ruptured sac and CSF leak. Here somebody will ask what are the long-term complications. I think in the click even you get the answer also. Please remember neurogenic bladder, hydrocephalus. It is said that even any patient with this type of the problem in the back, always check for the hydrocephalus. There may be club feet, contractures of ankles and knees, hip subluxation, tether spinal cord. Chiari crisis, you know that it's a herniation and then it will lead to the very emergency. 15% of children can develop the hydrocephalus with the Chiari 2 malformations. That is the, you know, the hindbrain or brainstem dysfunction, particularly the respiratory problems. Even, you know, spasticity can also be there sometimes in this patient, or Chiari malformation. And we know that it is the herniation through foramen magnum. Let us skip it to the last one. 12 years old boy brought from the school with complaints of weakness on the right side of body and aphasia of sudden onset while playing on the ground. He also had similar such episode 3 times in the last 2 months. Recovered within few days by itself. Every time. This is MRI angiography. What does it indicate?
Moyamoya disease. We have answers.
Which part is involved? In the exam hall, I'm just saying that we'll give the diagnosis, but examiner is not interested in diagnosis. Even here, it is shown with the arrow also. Middle cerebral artery on the left side, it is involved. Of course, what are the, as I said, even the MRI findings? MRI angiography is done. What is the probable diagnosis? As earlier you have answered, Moyamoya disease. Moyamoya, what do you mean by the Moyamoya? Anybody? What is the meaning of Moyamoya?
Puff of smoke. Dr. Divanshu.
Puff of smoke, yes. Here how it develops. That due to the chronic, usually bilateral, there is vasculopathy. And due to even the one particular vessel is involved also, vasculitis or something, then other collaterals will develop. And there is a character where the progressive narrowing of the terminal, and with this, most commonly intercarotid is involved of the, I will say, internal part of the intracranial part of the intercarotid artery. And that appearance will be like puff of smoke. In the Japanese language, they say moyamoya. That's why the name is derived like this. What is the radiological sign of angiography? All of us know it's a puff of smoke, which already we said, moyamoya in Japanese. Somebody may ask, what are the diseases that derive from the Japanese name? Some other conditions commonly which we discuss in our medical science. Anybody?
Kawasaki, they have answered.
Very good. Kawasaki is most common, everybody knows.
From T.
Then,
Takayasu.
Yes, Takayasu. That is a pulseless disease or reverse coarctation of aorta, what we say. The Kawasaki disease is name is derived from the name of the person. But Takayasu?
Kikuchi. Hashimoto.
Okay, Kikuchi Fujimoto. Japanese encephalitis. Hashimoto thyroiditis. Right? So these are the common conditions. Maybe some others, but probably very common which we are aware of. Somebody may ask the question. What are the conditions associated with moyamoya? Please remember, moyamoya is not the diagnosis. It is the, I will say, radio imaging picture, which can happen in various conditions. Even occasionally tuberculous meningitis, neurofibromatosis, sickle, commonly they present as a stroke. I think we had one patient few weeks back in our PG clinic from some institution, and we discussed the stroke. What are the treatment options? Medical, if possible, then aspirin to prevent the recurrent attacks. Surgical is the definitive. Now, direct vascularization and indirect vascularization also they do. So this type of the surgery is now available in our country also. Should we end over here?
Whatever you feel like.
Because already we have crossed the time, and my presentation is not going to end. So at some time we'll have to decide. I hope that purpose is served of the students for the OSCE and even to learn some of the conditions in the neurology. It's good that this time so many students were present even on the screen, responding even sometimes before I complete the question. So precisely even responses were there. Even not only the chat box, but they were vocal. That is on the contrary more appreciable point that they were responding. And even I will say very happy to see that different corners of the country, not only I will say just Ahmedabad or Gujarat, but many of the students now we know because they are interested participating in many of our PG sessions and with their frequent presence, we know. So it's certainly, I will say, good. And we hope that even you can send some suggestions to us. Then if you want to some changes, some modifications, I'm sure that our team will accept it, and we'll go, as it should be more beneficial to all of you, to the students. And we want to make it interesting, that more number of students should participate. It should be more useful to in the exam. You know, exam is not the final answer. It's one milestone. But beyond that, even in the practice also. And I'm sure that all of us, if we have come across such conditions, heard something, then in the practice also, tomorrow, suppose some patient comes, certainly we'll be able to diagnose and help the patient. So with these few words, I end over here. And let me express a word of gratitude to the organizers, particular President Dr. Jhankhana Ben, Secretary Dr. Nehal Ben. Yes, Dr. Lata is, I will say, managing the whole show.
Yeah.
And even all the students present over here. Thank you very much and good night. And again, probably every Thursday with some new type of the programs will be present. Thank you very much. I end over here. Over to you, Dr. Lata and the team.
Thank you, sir. Thank you. Again, it was very nice presentation. Nehal, ma'am, please, vote of thanks.
Thank you so much, Lata. You are always there with another help to the Baldev sir. The prompt response
pleasure, ma'am.
from the prompt responses from the chat, and sir is having that responses by your voice. So thank you so much for being there. Baldev sir is always there whenever there is the name of PG teaching. So sir was telling us some incidences about what he has seen about other teachers. But sir, we have seen you, how you made us. So we will be telling that to our students.
But my idea is really, Nehal, that when the presence of so many teachers, always we listen somebody, to be very, if somebody asks me, I can name some even 8 to 10 teachers that from whom I learned even various qualities, various methodologies, even not only pediatrics, also even living the life, how to try to become the good human being. And I think these are the things which is quite always useful in learning. As a teacher, I will say not only the subject or Nelson is sufficient. Of course, it is important aspect, but beyond that also. And when we listen such of the stories, we understand, what people were doing. Even some people are doing at present also. So that was also part of it. Thank you very much. Thank you and good night.
Good night.
Thank you, Jhankhana madam, for being there, and all the students. Thank you so much. Next Thursday, again, we are having an expert talk followed by the quiz. So please be there. Thank you.
I request the student that please give the suggestions and remain, I will say, present in the very big number with even the good responses, and make it even, I will say, not only live but the viral, so that even the people should come to know that something is going on. Even somebody is probably sleepy, but once attends, probably his sleep should disappear.
Yes.
And I'm sure that we can make it. We can make it.
Yes.
Thank you again, and good night to all of you. Next Thursday will be
Good night,
there.
ma'am. Good night, sir.
Good night.
you.
Good night. Good night.
Good night, sir.
Good night.
Good night, ma'am.
Good night. Good night.